Thank you very much, Dr. Del Rivero, for this great presentation. Now it's time to do our neuroendocrine tumor board. This is always a session I think that many of our patients enjoy as they get to observe how clinicians interact in a multidisciplinary fashion when they discuss a neuroendocrine tumor patient's case. Today on our tumor board, we have Dr. Soares from the University of Utah. We have Dr. Eads from the University of Pennsylvania, Dr. Halfdanarson from Mayo Clinic, Dr. Chandrasekharan from MD Anderson Cancer Center, and then our own Dr. Khan and Dr. Liao from the University of Chicago. We're very excited to present these two cases to you, and we hope that you'll enjoy it.
So welcome all to the NetRF Neuroendocrine Tumor Board. We're really happy to have you here, and thank you for taking the time out of your busy schedule. So Andy, why don't you get us started with the first case?
Okay, so our first case is a 45-year woman. She presented with right upper quadrant abdominal pain and also back pain. She also had flushing and night sweats and watery diarrhea. And she says she has occasional abdominal cramping after eating. So she went to her primary care doctor who did an abdominal ultrasound, and it showed multiple masses in the liver that was followed by a CT abdomen pelvis, which showed a terminal ileum lesion, mesenteric lymph nodes, enlarged liver with liver lesions, and then portal hepatis lymph nodes. And I'll show you the images in the next slide. But she had a liver biopsy, and that showed a well-differentiated neuroendocrine tumor. It was grade 2 and KSE7 of 10%. Her labs showed normal liver function. Her serotonin was 1423, and she had an echocardiogram that was essentially normal. So if you look at her CT abdomen pelvis, so on the left-hand side, you see in the circled area, that's where the terminal ileal lesion is. It's like a 2 by 3 centimeter lesion. And then on the right-hand picture, you see one of the examples of the mesenteric lymph nodes that she has. And this is her MRI abdomen, and this was done with EOVIS contrast, so hepatobiliary phase contrast, which really, really produces clear pictures of the liver lesions, as you can see here. Just show you two representative cuts of her MRI abdomen with EOVIS. And then this is her dotatate PET scan. This was gallium dotatate, and so it showed a lot of uptake in all of these liver lesions, as well as the terminal ileum lesion and the mesenteric lymph nodes. So basically, we have a 45-year woman who was newly diagnosed with a metastatic, well-differentiated grade 2 small bowel neuroendocrine tumor, and she has liver metastases. So I'm going to open this for discussion. How do we best approach this case? So I'll start by asking Dr. Keutgen, do you see a role for surgery here, either resection of the primary tumor or liver debulking surgery?
Thank you, Andy. So I think from a surgical perspective, there are two things that we look at, especially with small bowel neuroendocrine tumor. We look at the primary tumor, the size of the primary tumor, and if the primary tumor is causing any symptoms. You mentioned she had diarrhea. Was she complaining of any cramping or any pain after eating?
Yeah, she did say that after eating, she feels abdominal cramping, but she hasn't lost any weight and she's able to eat solid foods and keep everything down.
And then the second point is obviously from a liver debulking surgery, not all centers do that, but that's another question to ask. So one of the things that strikes me on the abdominal CT here on the left-hand side is that that lesion seems to be quite large. It seems to occupy a majority of the small bowel lumen. It's not that common actually that the primary tumors are that big. And certainly here you could see you have these white little streaks of contrast that fill the bowel lumen. And there really isn't much contrast that goes along the lesion here. So I would say that this is a near occlusive small bowel tumor. In addition to the story that she tells us with the cramping after she eats, I would suggest that this probably needs to be removed surgically, just in order to avoid a situation where she gets treated systemically and we end up having a bowel blockage that would interrupt this treatment and then potentially end up having to have an urgent or an emergent surgery, which are always more complicated and have higher rates of complications. From a liver debulking perspective, I think this is a little bit too enthusiastic for me. I think there are a lot of tumors here, and I don't think that this would be the first line of treatments, but I could certainly imagine that there might be a role for liver-directed therapy either now or at a later point.
Great, thank you. So, Dr. Khan, liver-directed therapy-wise, would she be a good candidate for this? And if so, what would you use? Would you use embolization, either blend embo or chemoembolization or radioembolization or Y90? And what about histotripsy? Everyone asks about that in clinic nowadays.
Yeah, so certainly there's a significant amount of liver disease here. I think that, addressing the small bowel tumor initially would be something kind of focus on primarily, and then maybe subsequently looking at performing liver-directed therapy. This is sort of diffuse, a bulky tumor both sides. And so I think in this case, I'd sort of favor a blend embolization. Not too much of a significant difference between blend embolization and TACE, especially based on kind of initial results of a recent trial, a RETNet trial. And then TARE, I would sort of favor for like larger, like single lesions. And so I think she's a good candidate for blend. We could do histotripsy as well. Once again, the histotripsy is a new technology, not a lot of data. We have performed it at our institution. And certainly some of those, if we go back to the MRI, there are a few of those that are pretty close to the front surface of the liver, which are look to be amenable to visualization with ultrasound. And so maybe treating one or two of those lesions and sort of hopefully stimulating a potential immune, getting some immunostimulation with the PRRT is a possibility. I think blend embolization may do a little bit more here. And then certainly, Andy, if I kick it back to you for systemic treatment, that might be more of the road to go down.
You mentioned something interesting. Is there any data to support this scopal effect, like the histotripsy engendering an immune response in specifically for neuroendocrine tumor patients?
Not any in human data specifically. Certainly, there's been some basic science and some mice models that have shown some upregulation based on cytokine release and antigen release, but nothing in human. And so that's
So we still need to wait for clinical trial data. Okay,
Correct,
great. Thank you.
Yeah.
And then for the oncologists in the room, what would we do for systemic therapy? What would you give this patient? So I'll pick on Dr. Chandrasekharan.
Thanks, Andy. So, in this patient, she was also had a functional tumor based on her symptomatology, flushing, and diarrhea. So, I think the consideration of a somatostatin analog is definitely, one of the first things in terms of timing, whether the surgeon takes the primary tumor before, after. I think ideally I would get her started on somatostatin analogs for the syndrome presented to the surgeon for consideration of the primary tumor, given her symptomatology would be the way to go. I think the question of first-line PRRT is interesting. I can see the patient has a Ki-67 of 10%, which is kind of the cutoff for the NETTER-2 trial, which looked at upfront PRRT as an option. These are patients within 6 months of diagnosis, and she probably meets the criteria. Personally, though, I think without a clear benefit on overall survival with upfront PRRT, I have not adopted it for the patients all upfront. Given the distribution of the disease and the symptomology, you could make an argument that PRRT has good data for symptom control, quality of life preservation, etc. But again, these are studied in the second line setting when I'm talking about the quality of life. So I think get the primary tumor out if symptomatic, start on SSA analog therapy first, and kind of reassess with imaging and symptoms later would be my choice.
Great. Would any of the oncologists here disagree and say this patient should, or you would start this patient on first-time PRRT?
So I wouldn't. So for a couple of reasons. So number one, we do not have data on overall survival with upfront PRRT. We know from NETTER-2 that progression-free survival was markedly longer with PRRT upfront. But it will also say that this patient would barely have made it onto the trial with the lowest possible KS7. And we have data, the somatostatin analog therapy works up front. So my take has been just to play that card first, the somatostatin analog card, and just see what mileage you get.
Great. Dr. Soares, Eads, any other thoughts?
Yeah, I agree. I think that's someone by the book will certainly meet the criteria, but I haven't incorporated it really in the first line setting. I think one thing that probably many of us will do is to scan this patient a little bit more closely. I typically scan patients with small bowel neuroendocrine tumors every 6 months, the majority of them. This patient is someone that will probably do a repeat MRI in the 3 months mark or 4 months mark, just to have a sense. Because I didn't have a sense from the beginning of the presentation of for how long she has been living with the symptoms to sort of indirectly guide me if it is someone that the disease suggests that's really truly indolent, or this is one of these tumors that might behave a little bit more aggressive that you would expect. So for these reasons, I will scan her in a little bit of a shorter timeline than I normally do.
If I could just add to that, I agree that starting with a somatostatin analog makes the most sense and is what I would do in this situation for both anti-tumor control and for hormone-mediated symptoms. But I agree with Eloisa as well that, wanting to take a look early would be wise, especially in someone who has a relatively large degree of tumor burden in the liver. And it is a patient with liver dominant disease. So oftentimes at our institution, we may consider doing somatostatin analog. And then if symptoms are either not optimally controlled, or if we're worried about the pace of disease in the liver, we'll layer on the embolization in addition to the somatostatin analog, just to try to make sure that we maintain good control over the liver, because in a patient with this distribution of disease, oftentimes the liver involvement is where we get into the most trouble.
Yeah, that's a great point. So this is the timeline. So she was diagnosed in September 2020. We started her on first-line lanreotide, and then because she was symptomatic from her primary tumor, she had surgical resection of the primary tumor, cholecystectomy, but also a liver wedge resection that showed a grade 2 well-differentiated neuroendocrine tumor, Ki67 6%. And then in April of 2021, so about 6 months later, there's mild increase in size of several of her liver mets, but her serotonin almost doubled and she was having worsening flushing and diarrhea. And so you can see here the tumors, they're only mildly increased in size. So for reference here, this lesion here went from 32 millimeters to 36, so 4 millimeter increase, but it seems like her symptoms are clearly worse. So what would we do next in this situation? Dr. Khan?
Yeah, I mean, at this point, I'd be a little bit more stronger advocate. Liver therapy. Still, we have bilivar disease, so suggest treating with blend embolization, breaking treatment up to like each lobe, kind of 4 weeks apart.
And then Dr. Keutgen already told us this was too much tumor for liver debulking. For the medical oncologist, would you change the systemic therapy at this juncture?
I would not necessarily do it, but I would obviously start prepping for it though. And so there is progression, there is an increase in the serotonin, and symptoms might be worsening. And we know that radioligand therapy with lutetium does help with symptoms. We have evidence from NETTER-1, we have retrospective data from the Netherlands. So I think this would be sort of the time where I would really start thinking of radioligand therapy. And personally, that's where I would go next.
So that's indeed what we did for this patient. So she had blind embolization, one lobe at a time. And then 9 months later, her MRI and dilated PET scan showed disease progressions. So you can see here on the dilated PET scan, there's progression in the liver, but also she seems to have developed new dilated avid retrocrural lymph nodes and then bone metastases in the T3 area. So Dr. Halfdanarson said that you would do PRT. Does anyone else agree or any other thoughts?
I think ideally, of course, with every patient, every discussion involves all the treatment options. So even at the prior step, I would want to have a good discussion about all the options. At this time, technically, you could think about any systemic therapy, everolimus, cabozantinib with the approval, or PRRT or a clinical trial if you have. With that discussion, if probably yes, I agree with Dr. Halfdanarson that I would be leaning towards PRRT. She's got definitely good receptor uptake, as one can see, kind of has also extrahepatic disease burden. But I'm not sure if at this progression, May of 2022, she had a symptom progression as well. But regardless, I think from a quality of life perspective / disease perspective, that may be a good next step. But again, there are patients who would take another option as well. So a discussion and then proceeding towards my code recommendation.
Okay. And everyone asks about alpha PRT nowadays. So what do we know about alpha PRT? And is it better than conventional Lutathera?
So alpha particle therapy, just a quick introduction to that. So it is the same concept as with lutetium-177 or Lutathera. We're delivering a radioactive particle to the tumor cells. It's given IV. It's sort of glued to a octreotide or lanreotide-like drug. It floats around in the body. It latches onto the tumor cells like two pieces of Velcro and deliver its radiation charge to the tumor. So alpha particles have much higher energy. They travel much less in terms of distance. And they have never been compared to beta particle therapy like lutetium. Those trials are actually coming. What we do know is that the two trials that have looked at something called lead-212 or Pb-212, there are two different types of that. The initial results are actually very promising, but the question is really, will it hold up over time? And so yes, there seems to be a higher response rate. We shrink more tumors and we shrink them more than we do with lutetium, at least seemingly. But the question is really, how long does it hold up? So I'd say if you have an alpha study, by all means introduce it, talk to your patient about possibly participating in that, but we don't have any comparative studies yet.
Great summary. So let's move on to the next slide. So she indeed was treated with PRRT with standard Lutathera, and then 2.5 years later, her scan showed disease progression. So this is an example. She had mild progression of many of her liver lesions, but this one in particular in segment 3 got significantly larger. And then she also developed new bone mets. As you can see here, they're all very small, very subtle. So at this juncture, what will we do next?
So especially when I have a patient who has one rogue lesion kind of growing faster than the others, I would think about rebiopsying the patient at that juncture, specifically the lesion that is growing disproportionately to the others, to make sure that we're still dealing with the tumor biology that we think we are. Oftentimes, over the course of having this disease for several years, we will see some grade creep. So the Ki-67 may increase over time and become maybe less likely to respond to things that well-differentiated tumors do. Provided that that still showed a grade 2 tumor that didn't seem too particularly aggressive, I would think of a couple of options. So sometimes, especially for a liver lesion that's kind of growing disproportionately, we will do some targeted embolization just to that lesion and then treat the rest of the disease sort of a different way. It also looks like this patient responded quite well to PRRT, and so could be considered perhaps for either retreatment with the standard PRRT with lutetium-177, dotatate, or could be a good candidate for alpha therapy, ideally on study, to give it another go that way.
Great, thank you. Dr. Chandrasekharan or Soares, any other systemic options you would consider here?
Yeah, if I may say, and I know that's not usually majority of standard of care, but this is when I see this this disagreement between the grow. In addition to chasing the lesion, I like to sometimes, if possible, do a FDG PET, because that helps me to decide if I'm going to go on a more systemic approach that could potentially even include more traditional chemotherapy. And if I see that there are several lesions that are positive on the FDG PET, my leaning towards that rather than just chasing one or the two lesions in the liver. And it's not infrequent that we see this thing. So that's one additional test or tool that could help, at least in my thought process, how to decide on next steps.
That's a great point. Dr. Chandrasekharan, any other systemic options you would consider?
Yeah, I think I would incorporate pretty much all the steps mentioned about if especially one or two lesions are growing, rebiopsy, FDG PET, which could also guide in choosing the lesion to biopsy. Ideally, you would go for an FDG ab lesion. I would probably also repeat a gallium PET just to see, because you may still have receptors retained in these patients. I think it's, again, even though she had a 2-year demonstrated stability post-PRRT, if there is this grade creep happening, we expect maybe even lesser from that PRRT if we repeat it. So again, I would still offer it as an option and discuss. We have very little data for everolimus in the grade creep setting or grade, higher grade. cabozantinib technically has data in grade 3, but that's a very small subset of patients. So I think it's a little hard. So I guess technically, again, a discussion, but I would maybe, if still receptor positive, go for a PRRT type of option if receptors are present, or consider an embolization to that one lesion, which is receptor agnostic, get the cancer to declare itself better as to what's going to do, and then decide the next option.
Right. Dr. Keutgen, any role for surgery here?
Surgery is a big biopsy, right? If you think about it, surgeons are just big biopsy people in the setting of metastatic disease. So it depends. So I would argue, having known this case actually, because this is our common patient, if I remember well, her symptoms got significantly worse again. Having learned from liver-directed therapy that the bland embo part, didn't really control symptoms very long, I would argue if it's just a few lesions that are rogue, that rather than just doing a biopsy, if she had a good response to PRT, and because she's symptomatic and her symptoms are getting worse and her serotonin is going up, if there's a role for debulking. And I would say it again depends on the overall liver tumor burden, but she hasn't been debulked yet. So certainly you can debulk after PRT. And interestingly, we see it more and more, that patients get PRT kind of not first line, but, second line after progression on long-acting octreotide, and now have had some response to it, the liver tumor burden decreased, but now they're slowly progressing again. So that doesn't really take them out of contention for debulking, especially in those cases, I would say, that have a high serotonin level and with worsening symptoms. So it might be an option in her, depending on what the scan looks like.
So we consider all these points that everyone brought up. This was shared decision making with the patient. So she decided to go through surgery. So she actually had liver debulking surgery in January. And so the pathology is very interesting. So still show a well-differentiated neuroendocrine tumor. But if you look at the different liver lesions that were taken out, so the segment 1 lesion, Ki-67, was 20%. Segment 3 was 45% with 40 mitoses. Segment 4B was only 1%. Segment 5 was 12.4%. And then segment 8 was 1.4%. And then we did next generation sequencing on this segment 3 lesion because the Ki-67 was highest. And so that showed RB1 LAT4 loss, low tumor mutation burden, and microsatellite stable disease. So like several of you were already alluding, there seems to be this great creep phenomenon going on. So Dr. East, how often do we see this in small bowel neuroendocrine tumor, and why do you think that causes this?
We actually see it quite a bit. Our group at Penn had looked at this actually and shown that with the grade creep phenomenon that the Ki-67 generally increases about 1% per year. This is a little bit more beyond that, but it's not uncommon for these tumors to actually be very heterogeneous, not just within cross tumors, but also within one tumor. So I think it's actually not too surprising that there are several different Ki-67s represented across all of these different segments. And I don't know if we necessarily have a great understanding of why one necessarily takes off. Certainly the next generation sequencing showing the RB1 loss is something that we do see in the higher grade tumors. Oftentimes it's more in the poorly differentiated setting as opposed to the still well differentiated histologies, but it's definitely demonstrating features that are suggesting that it's kind of transitioning into a more aggressive tumor biology.
Yeah, great points. So at this juncture, so she just had her liver debulking surgery and she's still on lanreotide. Will anyone offer additional or change in systemic therapy given this surgical pathology?
I would probably wait and see what happens. Technically, this is the rogue lesion, which is bad biology, but it's done for now. Hopefully she has symptom relief from this. And you didn't tell me if she still had receptors prior to this. I think she, per the gallium PET, probably did. So I would kind of wait it out and see what happens and treat based on that and not necessarily give something right away. I think this great creep is very interesting for all of us, as we know.
Yeah, so let's go to the next slide. So that's indeed what we did. So we waited and then let her recover from the surgery, continue the lanreotide, and then 6 months later, her scans unfortunately showed disease progression. So this is the MRI comparison between April and July. You can see there's a significant increase in her liver metastases. And this is a dotatate PET. So in addition to the worsening liver metastases, there's also now diffuse bone metastases. So what will we do in terms of treatment at this juncture? So Dr. Soares?
Yeah, I think I will do a two-step approach. Something that you can get right away. I'll start her on full fox and prep her, do up to 4 months or of full fox, hopefully get a little bit more control, and then set it up for potentially, if possible, repeated PRT, which probably have to be off label. I don't know if she would necessarily qualify for that trial. But unfortunately, this is a situation that the biology of disease is not being kind to us and to the patient, and you already have to start like really setting up boom, 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 all the steps because you're not outside of the initial PRT. Disease control is not being held for too long. And it takes a little bit of time to get PRT in place, right? So especially
Yeah,
if it's off label, so I will do full fox personally. But we'll love to see
great.
what my colleagues will do.
Yeah, Dr. Halfdanarson, what would you do?
So you have so one option you have is cabozantinib. So keep in mind cabozantinib will not control the syndrome, but refractory small bowel or non-pancreatic NETs may control the disease for about 8 to 9 months. Probably a bit shorter in this high grade. So that this is all based on data from the cabinet trial. There was not a whole lot of grade 3 patients there. So that probably would be what I would do next. So would
Yeah,
be cabozantinib, continue the somatostatin analog. If the syndrome is uncontrolled, you have two options. You can increase the dose of the somatostatin analog, even shorter the cycle, and you can add telotristat to control the serotonin production, keeping in mind that the cabozantinib is not going to do that. Or at least not the symptoms reliably. And then you have everolimus, but we have no data on everolimus, but we have, or not at least prospective data, but we have some retrospective studies, and we've all seen everolimus work in this situation. So we have, and
great.
repeat PRT an option too.
Okay, Dr. Chandrasekharan, what would you do in this situation?
Also, first say this is probably the most interesting part of the tumor board because you're gonna
Yeah,
get this different discussion and I guess maybe differing opinions, but still the same. But I'm gonna probably start by something that's probably everybody does, actually counsel the patient because I think a lot of times patients have this perception, I've been told I'm not gonna die from this cancer. This is a 45-year-old was diagnosed with a grade 2A indolent small bowel neuroendocrine tumor. Now, I think it's important to emphasize to the patient first this is not maybe quote the same disease they've been dealing with in the past few years. I think that is important because no matter what we do, probably in this situation, the benefit and the time it's going to have is going to be lesser than any other conventional therapy. With such a liver burden in such a short time, the threat of impending liver failure when this disease takes off is very real. I think we should counsel all our patients. We all do. I think this is a little bit more urgent situation. So I'll start there. I think I may lean towards what Dr. Soares was alluding to. Just based on the April to July scan that you showed, there was quite a bit of progression, RB loss, even though it was a well-differentiated neuroendocrine, but very high. It's kind of behaving like, to me, clinically a poorly differentiated. I have probably a little bit more faith in oxaliplatin or platinum-based regimen, but I'm glad to see she still has receptors, so I would not exclude PRRT. Certainly, I would have a discussion about cabozantinib, but maybe not my first choice in this situation. So,
great, thank you. And then last question, Dr. Eads, what would you do? And would this patient be a candidate for CAR T therapy?
So, yeah, that's an interesting question. So, I'm inclined to agree with Dr. Soares and Dr. Chandrasekharan in the sense that I am uncomfortable with the pace of disease. The rate of progression has been quite fast, and we're really going to want to be able to get good control, or ideally good control, in a short period of time. I probably would do an FDG PET to see again like how much of this disease looks FDG avid versus dotatate avid, and would favor some full fox, perhaps then followed by consolidation with PRRT. The other thing to remember about PRRT is that it does not work quickly, and it's a treatment that we administer over several months. So when you need a rapid response, it just isn't maybe the thing to be looking toward. As for the question about CAR T therapy, so certainly a very interesting area that we are investigating at Penn in this particular patient population. It's something only available through clinical trials at this time. It's not something that would be standard of care. I think that I would be a bit nervous about it in a patient with rapidly progressive disease like this. It takes time to go through the CAR T process. We have to harvest T cells from the patient, manufacture them to be targeted toward the cancer, and then give them back to the patient. And all of that takes some time. Additionally, I think we're still not quite certain about how safe it is in patients who have a large degree of liver burden. So in this particular instance, I might be cautious that way as well. But as we learn more about it and hopefully get faster at manufacturing the cells as well, it may be an option, but why we participate in trials.
Yeah, definitely. Thank you. Dr. Chandrasekharan, you had a
And
question,
then I don't know,
comment?
we are short on time, but I just wanted to throw a question out. I know we just had a big surgical biopsy that Dr. Keutgen gave us, but I'm wondering if even within that information, again, at quite a bit of progression, would anybody re-biopsy? What if the tumor mutation burden has increased or something? I know the phenomena has been described more in temozolomide exposed patients, but I just kind of wanted to throw that thing out there. I may consider biopsying again.
Great point. Great point. Well, thank you for bringing that up.
Thanks to all of you. It's not easy to get you all out here and doing this. So thank you very much.